Morning. It's a beautiful early spring day. It's so nice to see some sunshine and look forward to a weekend without rain. So we have much for which to be thankful. I want to welcome everyone to our Dr. Harold Alper Humanitarian Award Lecture and Award Presentation. This is a great day. We look forward to this every year for its meaning that is significant. Our program this morning is going to be followed by a brunch in the POB, and they'll have a photo session there with all of our nominees and their friends and supporters. You don't want to miss that. This brunch is incredible. So please plan to go directly to the POB at the conclusion of our program. And now, before I introduce our speaker, I'd like to introduce our dean, Dr. Bruce Shack.
Well, thank you. Thank you very much. It really is an honor for me, having only been here now for 3 or 4 years, to host this event, which is put on annually by the Alper family in honor of their father and patriarch, Dr. Harold Alper, as Dr. Ford mentioned. This is a great event. It recognizes compassion and care for patients that goes beyond the normal day-to-day activities that physicians and residents in training do. So we are very pleased to honor these nominees, and I know later this morning we will honor the winner of the Alper Award. But let me welcome all of you all here, and thank you for coming. Appreciate your support. Anything we can do in the dean's office for any of you guys, please don't hesitate to call me. I'll try to be there. I usually am until the chancellor kicks me out, so I'll be there. But welcome again. Thank you so much for coming. It's a great pleasure to see a good crowd here. I know the Alper family is very pleased to have this turnout, so thank you.
Thank you, Dean. We had a dinner last night with our nominees, and I made a statement, a point, that one of the great things about the world of medicine is the extraordinarily gifted and wonderful people that you get to meet that you probably would never have met otherwise. That's true with our speaker today. The chance of my meeting him and becoming a friend without this event is pretty slim. So I'm very thankful because of this program, and I'm thankful that he accepted our invitation. We're really honored this morning to have as our speaker a physician who's an expert on the compassionate practice of medicine. This is a doctor that Dr. Alper would have liked to know and work with. Dr. Steve Trzeciak is Chief of Medicine and professor at the Cooper Medical School of Rowan University in New Jersey. He's a gifted clinician, a scientist, an author, a speaker, and an influencer. And I direct you to take a moment to read his very, very impressive biography in your printed program. He's authored a book about compassionomics. That's a new term, but it's something I think we'll hear a lot more about. And his passion for compassionate care is going to be abundantly obvious to you this morning. Be sure and come to the brunch and meet him. You're going to want to meet him and talk with him. It's a pleasure to introduce Steve Trzeciak.
Thank you so much, Dr. Ford, for that introduction. It's been a pleasure to get to know you. And I'm just so grateful for the opportunity to be here and share this day with you all. I want to thank Dr. Ford and Dr. Shack, Dr. Panda, Bill Reynolds. And I also want to thank the nominees for letting me share in this moment with you, Drs. Jones and Sherwood and Stroud and Zachary. Most of all, I want to thank the Alper family. So thank you, Debbie and Chess and Carol, for making this possible. I got a chance to to get to know them a bit last night and hear all about Dr. Alper and learn about him and realize that he wasn't just a compassionate and special physician, he was a compassionate and special person. And for all those reasons, I'm just super thankful to be here with you all today. So for the first 20 years or so of my career, I studied resuscitation science. I'm an intensivist, so I'm a specialist in intensive care medicine. And my colleagues and I spent more than a decade culminating in some work where we were studying brain injury after cardiac arrest, and we were trying to find the optimal oxygen level after resuscitation from cardiac arrest that would be associated with the lowest risk of having permanent brain damage. Now, I study compassion in healthcare. That may seem to be a bit of a pivot or a change in trajectory. Of course it is. I'm going to share with you today the story of how I became interested in this topic that we now call compassionomics. And really it's been a journey through the evidence. I spent multiple years going through the scientific case for compassion in healthcare. And I became convicted, and I use that term deliberately. A belief is something you hold, a conviction is something that holds you, right? So I became convicted that compassion is beneficial for patients and for patient care and for those who care for patients, or healthcare providers. And it can be very powerful. So I'm going to share all that with you today. I do have some disclosures. I have a book, as Dr. Ford mentioned, it's called Compassionomics. I do occasionally receive honoraria for speaking to healthcare organizations and other organizations about compassion. I think the two most important disclosures, or maybe not disclosures, but just things that I'm thinking about that I want you to know before I start. The primary determinant of clinical outcome is clinical excellence. The primary determinant of clinical outcome is clinical excellence. So if you're a surgeon and you have a technical error, or you're a physician who prescribes the wrong medication, there's no amount of compassion that is going to undo that. So I don't have any magical thinking about compassion. Rather, it's compassion and clinical excellence gives us the best chance for the best outcome. It's not an either or, it's an and. And I just want to say that out front before everything I say today about compassion and the power of compassion should be in that framework. When our book first came out, Emma Seppala, who's a scientist at Stanford and frequent contributor to the Washington Post, wrote an article about our book, and the social media post, rather unfortunate in my opinion, the tagline was, would you rather have a physician who is compassionate or graduated at the top of the class in medical school? As if it's an either or. Don't take the bait on that line of thinking. It is not an either or, it is an and, okay? The last thing I want to say before I start is that you might be thinking that because I got invited to share this message about compassion with you all, that I must be the most compassionate doctor. And the truth, if I'm being honest, is that I'm just a work in progress. But now that I see all the data, we've curated all the evidence, and I see it quite clearly, I'm taking a new approach, and I'm trying to get better at compassion every day. Now, fortunately, thankfully, science shows that I can get better, and we're going to talk about that a little bit later. So I want to just assure you before I start that this change in trajectory of my research and my life's work, I wasn't in the market for any kind of a change. Quite the contrary. My research team and I, we were hitting every milestone for success. We were getting grants from the NIH, publishing in really good journals, and I was being invited to speak in scientific meetings extensively. So everything was going as planned. But then, an unexpected question from a 12-year-old turned everything upside down and literally made me change the trajectory of my life's work. So that 12-year-old was my son. And one day he came and he asked me for help. He said, Dad, I know you give a lot of talks. I have to give a talk for my class at school. Will you help me prepare mine? And I thought, this is going to be awesome. What a great opportunity for father-son bonding, right? Little did I know what was in store for me. So I said, of course, what's your talk about? So he reached into his backpack and he pulled out a sheet of paper and he set it down on my desk, and this was the topic that he was supposed to speak to for his class at school. What is the most pressing problem of our time? Now, I don't know what you all were doing in 7th grade. I was not doing what is the most pressing problem of our time. I was a little bit taken aback, but so I challenged him. So I didn't want him to tell the story that he could tell because he had all the right materials and this was a story that he could put together. I wanted him to really think about it. What do you really think is the most pressing problem of our time? Now, of course, there's no such thing, right? There is no one single most pressing problem of our time. It's what is the most pressing problem of our time through your lens of experience. For him, it was his lens of experience as a young person. Now, what he picked isn't what is important. What's important is that he actually believed it. And when you believe it, you can make a compelling case like he did to his classmates at school. When you challenge young people, sometimes they challenge you back. And so he asked me, through your lens of experience, what is the most pressing problem of our time? And I realized that what I was working on was super important. If you happen to have brain injury after cardiac arrest, it was very meaningful. It was fulfilling. But was it the most pressing problem of our time? And what would happen if I actually believed that I was working on it? And so it set off this period of great introspection for me, or midlife crisis, whatever you want to call it. But I thought about it, and then I found it. What I believe is the most pressing problem of our time through my lens of experience as a physician-scientist. So first I want to tell you a story. On February 27, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, 2 buses collided head-on. This is what was left of one of the buses. The extrication of victims was so complex that it literally made it into the annals of a disaster medicine textbook. 6 people died, but fortunately 56 people were saved. Now, 5 years later, researchers asked the question, what do survivors remember? They interviewed every survivor using a rigorous qualitative research methodology, and what they found was 2 common themes in the data. The first was expected. It was the physical pain that they felt at the moment of impact. But the other theme? A lack of compassion from the caregivers at the hospital. Now, the data in this research becomes even more compelling when you realize that the victims were taken to multiple different trauma centers. They all had the same experience. These data began to open my eyes to a stark reality. I believe that in healthcare, we're in the midst of a compassion crisis. Now, you might say, maybe we're just in a societal compassion crisis. Well, there's data for that, too. So University of Michigan meta-analysis studied young people over 2 decades and found that empathy is, which we're going to talk about in a minute, and the difference between empathy and compassion, but empathy is declining over the past 2 decades, and the rate of the decline is actually accelerating. A Harvard study of young people, so middle school and high school students, found that the vast majority of our middle school and high school students say that their parents value their achievements and accolades more than their kindness for others. And in a striking 2016 Pew Research study, nearly 1/3 of Americans said that they don't consider compassion for others to be among their core values. But healthcare is supposed to be different. Healthcare is supposed to be different. What do the data say there? So a recent study published in Health Affairs, so one of the most prominent health policy journals in the world, in my opinion, found that 46% of Americans say that our healthcare system, but also our healthcare providers, are not compassionate. Nearly half. This is, there's also compelling evidence, numerous research studies from very well-respected academic health systems show that physicians miss 60 to 90% of opportunities to respond to patients with compassion. In fact, in one study, it was found that physicians' statements of compassion to patients only comprised 1% of office visits. Data from the Mayo Clinic show that the average time to first interruption in an office visit with a patient when they're trying to tell you their main concern and why they're there, the median time to first interruption is 11 seconds. When also research shows that it only takes 26 seconds on average for patients to tell you what their main concern is. In my domain, critical care, there's a lot of evidence. For example, a Johns Hopkins study found that in 74% of interactions between the care team and patients and families in the ICU, there's an absence of any compassionate behaviors, either verbal or nonverbal. And in a very striking University of Washington study funded by the NIH, they found that in end-of-life conversations with patients and families in the ICU, fully 1/3 of those end-of-life conversations have no expression of compassion from the care team to the patients and families. We know that in healthcare we're in the midst of a burnout epidemic. One of the cornerstones of burnout is depersonalization and inability to make a personal connection. And I would argue to you where there's an inability to make a personal connection, there can, of course, be no compassion. But depersonalization is found to be very high in 35% of U.S. physicians, according to the most recent data. And in the era of electronic health records, there's evidence that healthcare providers spend more time looking into computer screens than looking their patients in the eyes. I'm going to share with you a work of art. Many of you are probably familiar with this. Luke Fields, The Doctor. We note that the physician here is completely locked in on his patient. This is the painting that I actually have in my office because for me it's a reminder of what caring for patients is supposed to be all about. I want to contrast this with a more recent work of art, this one. So this is published in JAMA in 2012. The person who submitted this was the pediatrician who's on the left side of your screen. The artist here was the patient, a 7-year-old girl. The pediatrician submitted this because he was horrified that this was how his patients saw him. What's the physician doing? Looking the other way into a computer screen. So that was then, and this is now. Based on all of these data that I've shared with you, I conclude we're in the midst of a compassion crisis. But here's the big question. So what? Does compassion really matter? Now, you might say, of course compassion matters. It's the cornerstone of the art of medicine. There's a moral and ethical responsibility to treat patients with compassion. Of course I agree. I've always agreed. I don't know anyone who doesn't agree with that, but that's not the question. The question is compassion just a nice to have or a moral or ethical obligation? Or are there evidence-based effects of compassion belonging in the science of medicine? And what is the evidence? For decades, very important voices in medicine have been calling for more compassion. And if I'm being honest, we haven't moved the needle at all. In fact, I just shared with you a bunch of data that we're going the wrong direction. So rather than taking a moral or ethical or sentimental emotional approach to this question, my colleague Anthony Mazzarelli and I, my co-author, we decided to take a scientific approach. What's the evidence? So I'm a research nerd by background, and so research nerds love methodology. And the first important part of methodology, our methodology, by the way, was systematic review, but you have to have a hypothesis. So our hypothesis, it's really a three-part hypothesis, is that compassion matters for patients, for patient care, and for those who care for patients. We used systematic review. We went through more than 1,000 scientific abstracts. In the book, there are more than 280 original science research papers cited. And really, we were testing if compassion matters not just in meaningful ways, but actually in measurable ways. So what I'm sharing with you today isn't really what I think or believe, but rather what we found after curating all the evidence and going through all the studies. I think it's important to, first of all, have nomenclature, have an understanding of nomenclature. And what is compassion? So compassion is defined, most scientists define compassion this way: an emotional response to another's pain or suffering involving an authentic desire to help. Compassion is an emotional response to another's pain or suffering involving an authentic desire to help. The operative word being response and help, operative words. It's a bit different from a very closely related term, empathy. Empathy is the detecting, feeling, and understanding component. But compassion goes beyond empathy, in that it also involves taking action to alleviate someone's pain or suffering to whatever extent possible. Just to keep it simple, that's what I like to do, we define it this way: empathy plus action equals compassion. We say that you can have compassion or you can have empathy through a one-way mirror, but you can't have compassion because that requires behaviors to connect with people and to offer help. There are neuroscience data to support this distinction in nomenclature. So functional MRI studies, so this functional MRI detects subtle differences in cerebral blood flow in such a way that you can identify what areas of the brain are being activated at any given moment. When you have empathy for a patient, you bear witness to pain and suffering, the pain center of your brain will light up. The statement, "I feel your pain," or that phrase, there's neuroscience underpinnings to that. You actually do feel someone's pain. You know that it's uncomfortable to bear witness to people suffering. You've experienced that before. But when you take action with compassion to alleviate someone's pain or suffering to some extent, it actually activates a different neural structure. It's an area of the brain that is considered a reward center, not a pain center, a reward center. It's associated with positive emotion, affiliation. It feels good to help others. You've experienced that as well. So there are neuroscience underpinnings to this distinction. So before diving into the data that compassion for patients is beneficial for patients in the healthcare domain, what about just human connection in general? I'm reminded of a study, the Harvard study of adult development. So it's been going on for more than 80 years, the longest running study that I'm aware of. They're on their 4th study director. They enrolled young people, Harvard students and others from Boston, and followed them over time. The overarching aim of the study was to find out what is the secret, what are the key determinants to good health and longevity. What they found, in my opinion, is striking. What they found is that the primary determinant of good health into your 80s was not some biomarker in your 50s. It wasn't your blood pressure, wasn't your cholesterol, wasn't your hemoglobin A1C. The primary determinant of good health and longevity into one's 80s was the quality of people's relationships in their 50s, relationships. On the flip side of this, we know that loneliness kills, literally. This has been studied very rigorously. Dr. Murthy, our former Surgeon General of the U.S., has focused quite recently, wrote a book about this. Loneliness kills. Loneliness causes people to be the same stress response when you're under extreme stress or threat. Those pathways that are activated in you are activated constantly when you're lonely as well. And that can do everything from trigger systemic inflammation to all sorts of, a whole host of adverse health effects associated with chronic stress. But loneliness kills. This has been shown repeatedly and is such a clear signal, in my opinion, in the data, and I'll give evidence for that. In the UK, they've appointed a public health official who is the Minister of Loneliness, which sounds like the worst job ever. I don't know who would sign up for that, but that just underscores that there's evidence that human connection matters for health. So what's the evidence that it also matters in health care? So I'm going to talk about the clinical effects of compassion for patients. Of the 280 original science research papers that we cite in Compassionomics, 100 or more, actually more than 100, are on effects for patients. Of course, I can't summarize 100 scientific papers for you in the short time that we have together, but I can give you a summary. Really, we bucketed them into 4 distinct categories: physiological effects, psychological effects, effects on quality of care, and effects on patient self-care, how people take care of themselves better when they're treated with compassion. So just to quickly go through some of these, in physiological effects, for example, 2 studies from the domain of anesthesiology published in the New England Journal and JAMA found years ago, actually, they tested in a randomized controlled trial special care from an anesthesiologist, what they called special care, from an anesthesiologist in the preoperative period. And this was a randomized trial where special care consisted of an additional visit from the anesthesiologist that was grounded in compassion, alleviating one's fears prior to going into the operating room, which is perhaps one of the most vulnerable times in a person's life. What they found is that patients randomized to special care not only had better achievement of optimal sedation, they were actually more calm and required less sedating medication. They also required less opiate pain medication following surgery. Pain is so complex. It's one of the most complex things in all of medicine. That's why there are actually specialists in pain medicine. There are so many, I'm not trying to reduce this and oversimplify it. There are so many different things that contribute to one's experience of pain. But it has been shown repeatedly, both in experimental science in the context of a laboratory and experimentally induced pain, as well as in the clinical setting, that compassion from a trusted other, whether it's a family member when it's an experimental study in a laboratory, or from a trusted healthcare provider in the context of healthcare, compassion for patients can attenuate and modulate one's experience of pain. Clinically, this has been shown in patients not only in postoperative period, but patients with low back pain, which is the #1 reason to miss work in the United States, abdominal pain related to irritable bowel syndrome, pain related to migraine headaches. The signal seems to be fairly consistent and actually lines up with what has been found in experimental studies of experimentally induced pain in a laboratory setting. But what about immune effects? So there's evidence that human connection can modulate one's immune function. So a University of Wisconsin study funded by the NIH found that in patients with a common cold, maximal compassion from a healthcare provider was associated not only with a change in the interleukin levels in their nasal washings, indicating enhanced immune response, but also a 15% reduction in the severity and duration of symptoms of the common cold. Colleagues from Jefferson University, which is right across the river from me in Philadelphia, have found that compassion from healthcare providers, specifically in their study physicians, is associated in patients with diabetes, associated with optimal 80% higher odds of optimal blood glucose control and 41% lower odds of acute metabolic complications requiring admission to the hospital. Why would that be? I think it's related to self-care and adherence to therapy, but we're going to talk about that in just a minute. There have been a number of studies that have found that compassion for others can have profound psychological effects. Now, to some extent, this might be intuitive to you, that compassion can attenuate emotional distress, psychological distress, but this has actually been found consistently, a signal consistently demonstrated in the psychology and psychiatry literature that, for example, in patients with depression, that the person of the therapist matters in a major way. And the number one determinant of the personal qualities of the therapist is their compassion. So compassion can alleviate depression symptoms among those that have depression. A Duke study from years ago found that compassion combats demoralization among patients with depression. That's their depression about their depression, and can give them hope. Compassion for others has also been shown to reduce anxiety and emotional distress in patients going through somatic disease, such as a bad diagnosis, like having cancer. Some of this might be fairly intuitive to you. I just want to share with you a quick story that sort of marries the physiological and the psychological. This is actually from a case report from 1985. A 35-year-old man was admitted to the ICU with septic shock and multiple organ failure. It didn't look like he was going to make it. Thankfully, he survived. He survived the initial sepsis insult, but he couldn't get off the ventilator. Hours turned into days, days turned into weeks, weeks turned into months. Thankfully, he eventually made it off the ventilator. When you're stuck on a ventilator in an ICU for a prolonged period of time, really dark things go through your mind. In this case report, it was written that the patient often had thoughts of, how can I get close enough to the edge of the bed to actually unplug my own ventilator? Unplug my own ventilator. And he knew what that would do because the patient was a physician, and the physician wrote his own case report in the literature. He said the only reason why he made it was because of his angels. Who do you think his angels were? The nurses. But not every nurse, and not just any nurse. In fact, the author said that I could detect within 30 seconds at change of shift whether or not the nurse actually cared. And when the nurse cared, it would buoy him up, buoy up his spirits, his hope, and he believed he could get off the ventilator. And if the nurse didn't care, it would crush his spirits, and his mind would go back to that dark place. How can I get over to that outlet and unplug my own ventilator? The author of this case report is a mentor of mine. He was actually the chair of medicine at Cooper before I was the chair of medicine at Cooper. His name's Dr. Ed Viner, and he is one of the main reasons why we've gone down this road and to study it. He lived through it, so he knows the effects. He then turned to me and said, you're a research guy. Help me science this up. It's important also to talk about patient self-care, how patients take care of themselves, because our behavior is such a powerful determinant of health. I want to share with you a study from Johns Hopkins University in 1,300 patients with HIV. HIV is a serious diagnosis. In 2020, it's also very controllable. The key determinant is you must take your medicine, and you must not miss doses. Adherence is crucial. Hopkins researchers studied these 1,300 patients with HIV, and they asked them a question. Does your HIV provider know you as a person? Know you as a person. They adjusted the analysis for every factor that they could measure that they knew was associated with adherence to antiretroviral therapy. And what they found was that knowing the patient as a person was associated with a 33% higher odds of adherence to therapy, but also a 20% higher odds of having no detectable virus in the blood. So think about that. This is an association, of course. It's not an experimental design. But the causal pathway makes sense. Know the patient as a person. The patient trusts you and believes in the therapy, which they also measured that, by the way. They actually take their medicine versus don't always take their medicine, and have no detectable virus in the blood. Compelling evidence, in my opinion, of the power of human connection to change how people take care of themselves. In terms of quality of care, in the interest of time, I'm not going to go through all of the evidence on this, but basically where there is evidence that people care less, and this is mostly taken from the burnout literature, there's evidence that depersonalization is associated with more medical errors. So depersonalization and compassion are not opposites. They're not opposites. But where there's an inability to make a personal connection, there can be no compassion. And there is evidence, mostly from a Mayo Clinic group that has studied this extensively, to find that where there is depersonalization, more medical errors occur. This is also true in surgeons, a study of almost 8,000 surgeons in the American College of Surgeons, that depersonalization is associated with subsequent higher incidence of major medical errors. Associations, of course, not necessarily cause an effect, but where there is less caring, there are more errors. So what ties that together? What's the possible mechanism? The Mayo Clinic group has found that it is cutting corners, cutting corners. So we've all been exposed at some point in our career with colleagues that we think really don't care. And they're also perhaps more likely to be sloppy about the work that they do. Well, where there is less caring, there are more errors, and cutting corners seems to be the mechanism. Importantly, for any trainees that are here in the audience, I want to be clear that compassion, as you go out and you try to build your practice, compassion is something that patients consistently say that they want. A Wall Street Journal survey study from years ago found that patients rank compassion in the caring parts of healthcare above all the competence things like where you went to, where you did your training, where you went to medical school, things that physicians often think matter. That isn't what patients value because, in my opinion, patients give people the benefit of the doubt. They want to believe everybody's competent. So what they want is the caring aspects of healthcare. And there is very compelling evidence that compassion communicates competence. Compassion communicates competence. Patients don't know your med school transcript. They don't know what you got on the what your board scores are. But they can detect whether or not they believe that you care. And research, numerous studies show that when patients perceive caring from the physician, they also perceive that physician to be more competent. Something important to keep in mind as you go out into the world and build your practice. In the interest of time, I'm going to move through this, and I'm just going to, I often get asked, so compassionomics is about the why. Why should we treat patients with compassion? What's the evidence that compassion actually matters? Then people ask me, well, what's the what? Like, what are the 3 things I can do? What's the 5-point checklist that I can do to be more compassionate? It's really, in my opinion, all about mindset. It's all about mindset. And specifically as it relates to the evidence, and realize that there's evidence behind treating people with compassion, but also time and training. Here's what I mean by that. A recent study from Harvard University published in the Journal General Internal Medicine found that 56% of the physicians in this study said that they don't have time for compassion. But it begs the question, how much time does it actually take? I'm reminded of some classical studies from the psychology domain where there was a Good Samaritan study from years ago from Princeton Theological Seminary where they trained, these were pastors in training in seminary, and they studied the Good Samaritan parable from the Bible. And then they instructed the students, they randomized them to go down to the other end of campus where they were going to complete their next task. They randomized them to one group that got the conventional instructions to go to the other end of the campus for the next task. And then in the other group, they said, oh, by the way, you're already 10 minutes late. You better hurry. What they found was this. There was a man disheveled, moaning, obviously in extreme suffering, lying in an alleyway between two buildings, and all of the seminarians in this study passed right through by this person. The person was what they call a Confederate, a faker, right? Lying in the gutter. What they found is that the people who were randomized to being told that they were in a hurry, only 10% of them stopped to help, versus 60% in the group that had just heard the Good Samaritan, had teaching about the Good Samaritan parable. And there was the major determinant, after adjusting for everything else, including the personal attributes of the seminarians, was being in a hurry, was the major determinant whether or not they stopped to help. So how much time does compassion actually take? So researchers from Johns Hopkins University studied this in breast cancer survivors. And the primary outcome measure for their study was anxiety. And if you've ever been touched by a cancer diagnosis, or someone close to you has been touched by a cancer diagnosis, you know that anxiety is a pretty important outcome measure. So they randomized these cancer survivors to two different consultations. One was standard, just informational, and the other was the same standard informational consultation from the oncologist with just a little bit more. I could describe it for you, but instead I'm just going to read it to you. From the oncologist at the beginning of the consultation: I know this is a tough experience to go through, and I want you to know that I'm here with you. Some of the things that I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me if something I say is confusing or doesn't make sense. We are here together, and we'll go through this together. And then at the end of the consultation, the oncologist said, I know this is a tough time for you, and I want to emphasize again, we are in this together. I will be with you each step along the way. So how long did that take? 40 seconds. A randomized trial shows that 40 seconds of compassion made a measurable, statistically significant difference in patients' anxiety. In our book, we go through the 5 studies that we're aware of that have actually timed compassion, effective compassionate communications, and we found that all of them took less than 60 seconds. So maybe it's really not time, it's our mindset about time. It's our mindset about time. So there was a study from the Wharton School at the University of Pennsylvania from years ago, which found, they studied time affluency. Time affluency. That was the term that they used to refer to people who are the state of believing you have plenty of time. You're not in a hurry. And they randomized people to 4 different uses of time and tested how it affected how they felt about the time that they had. They randomized them to wasting time, getting a windfall of free time, spending time on themselves, and lastly, spending time on other people. Only one of these 4 uses of time increased time affluency, making people feel that they have more time. Which one do you think it was? Spending time on other people. So giving time actually gives you time from how you feel about your time. It actually changes how you feel about the time that you have. In one other point, sometimes people bristle at the 40 seconds idea because they actually say being compassionate doesn't actually take any time at all. You can go through your day with the same brusque efficiency, letting everybody know exactly how busy you are, or you can treat everybody with compassion, and if we held a stopwatch to it, you wouldn't be able to detect a difference. I think that there's a lot of credence to that. This is the other part of mindset that I think is important. So the 3 parts of mindset are evidence, recognizing that there's an evidence base behind compassion. Time, realizing that we actually do have time to treat people with compassion. And lastly, change is possible. Change is possible. I used to think that people were either wired for compassion or they're not. It's something that's in the DNA, the fabric of who you are. When you actually look in the biomedical literature and in the psychology domain, in the psychology literature, there's actually quite a bit of compelling evidence that compassionate behaviors can, in fact, be learned. In fact, my colleagues and I did a study that we just published over the summer in PLUS ONE, where we analyzed every study which described a curriculum for teaching empathy or compassion to physicians or physicians in training. We found that there were 53 studies in the totality of the biomedical literature. And strikingly, 75% of these studies, the intervention, the training, moved the needle on empathy or compassion in at least one outcome measure. So, of course, the training programs, they were heterogeneous. But for whatever outcome measure of interest they had, 75% of these studies, the intervention worked, quote unquote. And we think that that's pretty compelling. Matthew Ricard, who's a scientist and an expert in compassion science, uses the analogy of a javelin. Now, I'm not a great javelin thrower, probably, right? And maybe you're not either. But if we went outside to throw the javelin, we could throw it some distance, but if we went and practiced every single day, we could throw it a little bit farther, a little bit farther, a little bit farther. There's no doubt that there's something in predisposition for compassion. I'm not saying there's not, but if you practice, if you train, if you try to get better, you could throw it a little bit farther every day. But the key part is that you have to believe that you can. You have to believe that you can. So Carol Dweck is a world-famous researcher in education, and she published a book called Mindset. And her book is about a growth mindset versus a fixed mindset. If you have a growth mindset, you believe that everything is a skill, not a trait. So if you fail at something, you just need to try a little bit harder, work a little bit more, you'll get better. If you have a fixed mindset, you believe everything is a trait, then when you fail, you believe you're a failure, right? And what she found in her research in education in young people is that young people who have a growth mindset and believe that everything's a skill, not a trait, they try harder because they're not afraid of failing. And in the end, they do better over time. What a lot of people don't know is that she's also studied compassion. She and her colleagues did a study of compassion and found that we can get better with our empathy, our feeling, understanding, detection, and our compassionate behaviors for others, but we must have a growth mindset and believe that we actually can. What she found is that people who have a fixed mindset and might say things like, well, I'm not a touchy-feely person or something like that, those people never will get better because they believe that they can't. And so that's super important. In the few minutes that I have left, I'm going to talk about burnout. So you're aware that we have an epidemic of burnout in healthcare. And I don't know about you, but actually I hate burnout talks. The reason why I hate burnout talks is they're super depressing. I almost never learn anything actionable. And it seems to take up like all the oxygen in the room whenever you go to a conference, right? Burnout, burnout, burnout. Well, some people say we don't have a healthcare system, we have a sick care system. It's focused on sickness, we should be focused on health. I think the same way about burnout. I don't know why we always talk about burnout. Let's start talking about resilience. And look at people who are resilient. What is it about what they're doing that's different from everybody else that allows them to be resilient? The evidence shows that compassion and human connection, and specifically relationships, can be the antidote to burnout. It can be protective against developing burnout and can be an antidote for burnout for those that are in the throes of burnout. Relationships matter, not only for health, but for resilience and resistance to burnout. There's compelling evidence that our self-care techniques, how we care for ourselves, there was an NIH-sponsored study about this just recently, that is becoming more and more solitary pursuits for self-care, rather than what historically it used to be building community and the relational aspects that would give us our resilience. And we sought resilience in relationships with other people rather than solitary pursuits. historically, the treatments for burnout are what I like to call escapism. Get away, go on vacation, take more nature hikes, do yoga, whatever. All of that's super important, and I believe that work-life balance is super important. There's no doubt about that. I don't think anyone would argue that. But I wasn't buying it, that the secret to resilience and resistance to burnout was just getting away from our patients as much as possible. It doesn't compute for me. There has to be something fundamentally different at the point of care. Now, I remember when I was a student and a resident, I was taught, don't care too much because you'll get burned out. Don't care too much. It puts you at risk for burnout. That was like in the hidden curriculum that I learned coming up through medical training. The problem is that when you look in the evidence, you don't see that. If that was true, in any study that tested the association between compassion and burnout, they would go in the same direction. High compassion, high burnout, low compassion, low burnout. What you find in the literature when you look, and this was summarized in a recent meta-analysis of high quality, is that there is an association, but it's inverse. Inverse. High compassion, low burnout, low compassion, high burnout. Now, some people want to just jump to causation and say, well, yeah, if you're burned out, that just crushes compassion. But actually, the preponderance of evidence in the literature actually suggests something different. It suggests that those who have compassion and build relationships with their patients that are meaningful, they're more resistant to burnout under the same amount of stress. Why? Because they're having the fulfilling part of healthcare. See, if you don't have the fulfilling part of what it means to take care of patients, then you just have a super stressful job. So those people that invest in relationships with their patients actually have lower risk of burnout over time. It's not my opinion, that's just what we found in the literature. And there was an Emory randomized controlled trial about compassion training in physicians in training. What they found was that compassion training not only increased their compassionate behaviors, it also reduced their depression symptoms, and the magnitude of the effect was the greatest in the physicians in training who had the most depressive symptoms at the start of the trial. In this study, which was in the Harvard Business Review, this is, I think, an important report. What Candy Weirns and colleagues did is that they studied chief medical officers. Chief medical officers, that's a pretty stressful job. What they found is that these people had tremendous stress, but they had less burnout than would be expected. And when they interviewed those people to figure out why they weren't burned out, they found a common theme. 91% of them said that they get their resilience from compassion for others. So that human connection is what was protective for them. Lastly, I'm just going to tell you a very quick story. This is where the science meets the personal. So I'm an intensivist, and as an intensivist, you often meet people on the worst day of their life. And after doing that for 20 years, I came to the stark realization that I personally had every symptom of burnout, every single one. And the odds are that about half the people in this room have some idea of what I'm talking about. That can be a dark place. What was I supposed to do? Well, I'm a research nerd, so I went to the literature, and now newly armed with the data that compassion can be a powerful therapy for the giver, too, I decided to test the compassion hypothesis for myself. And I call this my N of 1 experiment, because there was only one person in this experiment. It was me. And I decided, knowing that compassion can be a powerful therapy for the giver, too, I'm going to be very intentional about this and care more, not less. Sit down and have more family meetings, not less. Lean in, perhaps, rather than pulling back and detaching and escapism. I did that not only with my patients, but with my colleagues. I did it at home. Relationships build resilience. That was when the fog of burnout began to lift for me. Changed everything. So if you're going through burnout, and by the way, you don't have to be a healthcare provider to have burnout. Let's be clear about that, right? Test the compassion hypothesis for yourself. Try it. See how it transforms your experience. So this was the big question I posed to you. Does compassion really matter? 1,000 scientific abstracts, 280 original science research papers, and 1 life-changing N of 1 experiment now behind me, I conclude with confidence compassion matters for patients, for patient care, and for those who care for patients. There's science in the art of medicine, and the science is strong. And we call it compassionomics because we consider it to be the convergence of the science and the art of medicine. The last thing I want to say before I go is this. You are powerful. You are powerful. What I mean by that is you don't have to have graduated from your training program already to treat patients with compassion. You don't even have to be in training. You don't have to have any medical background whatsoever to treat people with compassion. But the evidence in the science shows that it can have a meaningful impact, not only for others, the recipients, but for the giver too. So I just want to thank everybody for the honor of being here today. I want to thank the nominees for letting me share in this moment with you. I want to thank Dr. Ford, Dr. Shack, Dr. Panda, the whole Alper family. What a tremendous honor to be in something that's just associated with your dad. I thank you all for your attention today, and it's been an honor to be here. Thank you.
Well, Dr. Treziak, you've touched us all, and I encourage you. I think you'll probably be very motivated to come to the brunch at the conclusion and speak with Dr. Treziak, and I'm sure you may have some questions, and I'd like for you to hold those for the brunch. You know, we're here because of Dr. Alper. The entire event is in honor of him and a reflection of his lifetime work as a compassionate surgeon. Dr. Alper began practice here in Chattanooga in 1947, and he was appointed to the University of Tennessee College of Medicine surgery faculty as a clinical associate professor in '76. He was a driving force behind the establishment of the Chattanooga-Hamilton County Speech and Hearing Center, and he pioneered microscopic and laser surgery in Chattanooga. He was a recognized leader in academic and organized medicine, and he was recognized by his patients and colleagues as an extraordinarily competent and compassionate doctor. When you count the students and residents that he taught and the patients that he treated, Dr. Alper touched thousands of lives. So the Alper family established an endowment through the Baroness Foundation to enable our medical school in Erlanger to present an annual lecture on the humanistic, compassionate practice of medicine, and also recognize an outstanding resident physician who is completing his or her training here, who's exemplified the qualities of integrity, respect, and exceptional compassion. So we all owe a debt of gratitude to the family of Dr. Alper, and it's my pleasure to introduce them individually to you. First, Dr. Chess Alper, son, and his wife, Carol, daughter and sister, Debbie Alper. And I want to recognize another son, Jeffrey Alper, who could not be here today. So now I'd like to, it's a pleasure to invite Dr. Chess Alper to the podium to tell us a little bit more about his father and this award.
Thank you, Dr. Ford, and I just want to thank you and Dr. Shack and all your staff, Pam and Dee, for putting on this event every year and doing such a great job of it. I want to thank all of you who come each year to honor these nominees. And, you know, as I listen to Dr. Terziak, I kept hearing my dad's voice. One of the things that and this is, every one of you have heard this before, and it kind of sums up, I think, his philosophy, and that is that, you know, people don't care how much you know until they know how much you care. That's probably the bottom line to all of this. The other thing is that I was glad to hear you talk about how much time it takes to be compassionate. Desires are, what their expectations are. The other thing I think that really stood out about my dad, not just in his personal life, but just in his professional life, because he was consistent, always, in the fact that he respected everyone, showed everyone the same level of respect, whether they were the head of a medical department or a patient in his waiting room. So, treating everyone with respect, to me, is the key. It's the thing that also comes back to you and makes what you do, make you feel like what you do is worthwhile and that you're being successful with your patients. So with that in mind, I just want to congratulate the nominees. We had a wonderful dinner last night. It's, on one hand, I'm always amazed. You know, this is the 13th year for this award. Every year, the nominees are outstanding. There are people who weren't nominated who are outstanding as well. And I think to be recognized by your peers is one of the greatest gifts that you can receive. So with that in mind, Dr. Ford.
Okay. Yes, sir. Thank you, Dr. Alper. Now it's a pleasure to introduce our nominees to you. This was extraordinarily difficult. I'm glad I was not a judge this year. But in any type of competition, there can only be a winner, one winner, and that is who we have today. As I call your name, please come forward and stay with us. I don't think you'll mind me mentioning that every nominee is getting a $500 award, and the winner is getting a $1,500 award. So there's going to be some good weekends here from some of our residents. Nominations are from General Surgery, Dr. Veronica Zachary. From Internal Medicine, Dr. Jamie Jones. From Pediatrics, our nominee had made plans for a trip before she was nominated, and she can't be here. But through the miracle of modern technology, she's going to be with us, we hope, in just a moment. And from Pediatrics, Dr. Meredith Stroud. Pam, who is coming forward? Dr. Garcia? Or yes, Dr. Garcia, Program Director. Thank you, Dr. Garcia. Meredith, can you hear us?
I can.
Isn't this great? Amazing. It actually worked. I was so totally prepared for this not to work. And finally, and certainly not least, Dr. Laura Sherwood from Family Medicine, who is staying in Chattanooga. So it's a pleasure to announce the winner of the 2020 Dr. Alper Humanitarian Award from Pediatrics. Live and in person.
Wow,
Meredith
thank
Stroud.
you all so much. And again, I'm so saddened that I cannot be there personally. But thank you. I was very honored just to be nominated for this award. Each of the nominees chose to enter medicine in order to really help others, and so to a degree, we all deserve this award. But I am deeply moved and honored again to be the representative for this year, and want to thank the UT College of Medicine and the Baroness Foundation, and of course, the family of Dr. Alper for this recognition. Thank you all so much. It means truly a lot to be recognized for this. I am grateful for the people in my life that have helped shape the values that direct my work and my life. I thank my mom and my dad and my brother for instilling in me the importance of helping others and serving those that are less fortunate than myself. And of course, my husband, Talon, for his constant support and encouragement as I pursued my desire to be a pediatrician. And of course, my attendings, and Dr. Garcia for over the past 3 years, who have been absolutely wonderful role models, exemplifying the integrity and compassion and level of service that those we care for truly need. It is through all of these people that I have learned that the skills of a physician, like you said, must go beyond the science and beyond the medicine, like what Dr. Trezak was explaining earlier. And so they must include the ability to comfort a distraught family, to be an advocate for the continuous improvement of patient care, and to be dedicated to the community that we serve. They have all helped me strive to be the type of skilled and compassionate community pediatrician that Dr. Alpertz was, and what he continues to encourage and recognize through this award. So thank you again. I'm deeply honored and saddened that I cannot be there personally, but thank you.
Thank you, and congratulations. I want to again thank the Alper family, the Baroness Foundation, the Dean's Office, specifically Pam Scott, Bill Reynolds, Liz Jones, the support of the Dean. This is a wonderful event, and we're so privileged to be able to do this year after year. Please come to the brunch in the POB right now, and you get to meet Dr. Trezak and speak with him. So we'll see you in a few minutes. Thank you.